Good afternoon, everybody. Thank you very much, Amal, for kind introduction. I think inhaler therapy is something which has been very much in use over the last few years, and there are a lot of issues regarding inhalers, and I thought it's important to address some of these issues. So aerosol therapy, I mean, basically what we are doing is we are aerosolizing a substance and giving to the patient as therapy. Of course, since ancient times, people thought that asthma was caused by demons, spirits, foreign gods, and treatment. There were lots of various treatment, including burning incense to please the gods, and inhalation of fumes from the Datura plant was done 2000 BC in India. And if you take the Roman times in UK and in Rome, healing effects of water and steam inhalation for various respiratory illnesses were carried out, and these were sort of practiced widely. And in the Middle East, you have these water seal smoking pipes giving various inhalational agents have been used as medicinal purposes as well. So basically what we are doing is we are using a suspension of a fine solid or a liquid particles, giving it into the air and suspending it in air, and these are inhaled into the body. The particles should be large as not to diffuse like gas molecules. If they diffuse, they will just diffuse out and they wouldn't go into the lung. But they should be sufficiently small to remain in the air for some time. So they should be not too large, not too small. So basically, I mean, most of the aerosol therapy, inhaler therapy is used basically in the majority in asthma and COPD. So I will sort of go talk more on that. So the advantage is that we are getting the drug directly into the local site where it is needed. As you know, the primary site of asthma is in the lungs, although it can affect any organ as in COPD. But so we are getting the drug directly to the site, and therefore side effects and the amount of drug we are using is very minimal. Therefore, there is faster onset of action. Lower dose of the medication is required. As you know, the inhaler therapy is in micrograms rather than in milligrams as we use our usual drug doses, and therefore they have lower side effects because the the effects into the body are minimal and local effect is higher. So therefore the success of this aerosol therapy is dependent on the ability to send the drug into the lung, adequate amount of drug to the lung. Unfortunately, I mean, it's not like the skin where you just apply it directly onto the site where it is needed. It has to go through the mouth, pharynx, trachea into the lungs. So therefore there is a bit of a dead space there where we should not be having the drug deposited in those areas. Of course, the main advantage is that this has less side effects. But when we consider the deposition of drugs, there are three main things which we need to think of when we are doing inhaler therapy. One is, of course, the device. So it's a combination of the device. We need to consider the aerosol formulation and, of course, the patient factors and technique, because all three together will only give you successful delivery of the drug to where it is needed. So aerosol formulation is a very important aspect when you are choosing this aerosol therapy, and I'm not going into details here because my lecture is mainly not on this, but I will just take the 2022 asthma guideline just to highlight a few points. Now this is the 2022 GINA guideline on asthma, and as you probably know, these guidelines have made a dramatic change in 2019. Before 2019, in this step 1, that is very mild asthma, few symptoms, less than once a week, what we gave was as and when needed salbutamol or beta agonist. But in the newer guidelines since 2019, we have made a dramatic change here, and we have put that in steps 1 and 2, even mild and step 2 asthma, the drug of choice actually is now as needed low dose inhaled corticosteroid with formoterol. The advantage of formoterol, it is a reliever as well as a long-term controller. The second option is if you use a short-acting beta agonist, that is the salbutamol, which we have in our setting, you need to take an inhaled corticosteroid as well, rather than previously you giving a lot of salbutamol. So when we were registrars, when we were interns, I mean, there was a lot of salbutamol being used. A lot of people were on salbutamol. In the last few years of my practice, maybe the last 10 years, the amount of salbutamol I have used for patients is extremely low. Very few patients get a salbutamol inhaler from me. So I'm going on this regime. So this is coming into the guidelines now. And why do we say that? Well, it's been shown that patients with apparently mild asthma are still at risk of getting adverse events. And these mild asthmatics, 30 to 70% of adults with acute asthma have had mild asthma, only mild asthma. And 16% of patients with near fatal asthma actually have been in this category. And 15 to 27% of patients dying of asthma have actually got this treatment of only salbutamol. So this is not only a category where although it is mild asthma, you can disregard and say take an inhaler whenever needed with salbutamol. So this has made a dramatic change in the management of asthma, especially in the mild asthmatics. Also, exacerbation of triggers are unpredictable. Viruses, pollens, pollution, poor adherence, all that has made this, and as you know, these days we are having a lot of wheezing around. And also with the pandemic of COVID, we have had lots of people getting wheezing. And of course, giving oral corticosteroids, oral steroids, oral prednisolone, dexamethasone, whatever the oral corticosteroid, repeatedly has been shown that you have a high risk of complications. So therefore, treating with salbutamol alone is now not recommended, and therefore this has made a dramatic change in the management of asthma, which has been the sort of mainstay of asthma treatment over the last 50 years. So where asthma was thought to be bronchoconstriction, but we now know bronchoconstriction is just one part of it, and it is mainly the inflammation. So therefore there is a lot of evidence to say that giving an inhaled corticosteroid, even giving inhaled corticosteroid with the short-acting beta agonist or with the long-acting beta agonist formoterol is beneficial in these patients. On the other hand, one of the other aspects, so that's just touching upon some of the important areas when we think about inhaler therapy. In COPD, this is COPD management 2022 gold guideline. Again, I just want to highlight a few facts about use of inhalers. We actually categorize these patients very clinically actually into groups A, B, C and D how do you categorize? If we just look at their exacerbation history, if they have had a COPD exacerbation in the last 1 year, so if you have had one or more exacerbations of COPD, you fall into yes or no. So if you have had one, you fall into yes. And then on the x-axis, you have the MMRC scoring of shortness of breath. So basically, MMRC grade 0 to 1 or 2 or 3. If it is 2 or 3, that means you are having exertion, shortness of breath on moderate exertion, and these patients fall into this B or D, while less than MMRC, that is 0 or no shortness of breath, or just very very severe exertion, they have a mild shortness of breath, they fall into A or C category. So with this, which you can do clinically, you can just, every visit look at a COPD and you can classify them according to this guideline. I'm sorry, I have sort of missed one slide here. So once you categorize them into A, B, C and D, right, treatment in category A is usually you can give as and when needed bronchodilation is A. B is where you give long-acting bronchodilators, maybe long-term, and either muscarinic antagonists like tiotropium or formoterol or salmeterol, long-acting bronchodilators. C is again a combination of these long-acting bronchodilators. Tiotropium is preferred over long-acting beta agonist. So in C category, so where they have more exacerbations, less shortness of breath. So these are phenotypes. D is where the patients have repeated exacerbations and are very short of breath, are having difficulty breathing with mild exertion, mild to moderate exertion. These patients we categorize into the severe category of D, and in these patients there is a indication you can give a inhaled corticosteroid, or corticosteroid is indicated for long-term controlling of this patient. Again, they have classified in these patients, if you have a eosinophil count less than 200, then again the side effects of the inhaled steroids with possibility of infection is higher. So therefore, you better avoid giving steroids in them. And in patients who have a eosinophil count more than 300 are the people who will get inhaled corticosteroid in addition to the long-acting bronchodilators. So this is some area I thought I will emphasize here. We'll see a lot of diagnosis cards. Diagnosis COPD, acute exacerbation, patient is on long-term Beclate and salbutamol, right? So this is totally out, right? That is, there is no indication to give in a COPD patient Beclate and aspirin, right? You are just wasting the drug. You are putting the patient at risk of repeated infections. So you are actually harming the patient. So we see enough and more diagnosis still. Unfortunately, with this present economic crisis, we are having major problems with inhalers, and therefore patients are on various things at the moment, and many patients are without any inhalers and coming with exacerbations. So this is something which we need to think about when we are thinking of a COPD, plain and simple COPD without asthma. So without asthma, COPD, bronchodilators only. Inhaled corticosteroids have a place in very severe COPD with repeated exacerbations. So the next thing we need to think of is the drug delivery into the lung. If the particle size is more than 5 micrometers, it will deposit in the upper airway, nose, throat, pharynx area. Below the neck, you get deposition of particles 2 to 5 micrometers, and this is the area we are concerned with inhalers. So the inhalers are designed to get this 2 to 5 micrometer diameter of the particle, and then you get the good clinical effect. If you get less than 2 micrometers, and if you take the pollution statistics, you will always get 2.5 micrometers small size particles as one of the major pollutant measures, and there is systemic absorption there, and therefore you will get more systemic absorption, more side effects in the body as well. So that's something to think about when you think of the drug and of course the delivery device. Now when you think of the other aspect is the equipment you are going to use to get this drug. It's not swallowing a tablet, it's something more than that, because you need a delivery system to deliver the drug into the system. So you have different methods of delivery. One is of course the nebulizers. You have two main kinds of nebulizers, the jet and the ultrasonic nebulizers and the mesh nebulizers. I'm sorry, I have not put it here. So there are three kinds of nebulizers. What we use in our wards commonly is the jet nebulizer, which is basically the one which we use. Then of course we have the metered dose inhalers, which we use, the Seroflow and various things, pressurized metered dose inhalers, and you can use with a spacer or without a spacer. And then you have the dry powder inhalers, where the particle size is a little bigger, but again the delivery is by the same size. And in these dry powder inhalers you have some which deliver one dose and some which have multiple doses. Now if you take the pressurized metered dose inhaler, it has the drug in a container which has a propellant and the drug suspension. So there are two things in it. So so you need to think of this when you are giving this inhaler. I will talk about it a little bit later. And then there is a metering valve here, so that to give a constant volume of the drug to the patient, and of course the mouthpiece where you then inhale. One of the most advantages of the pressurized metered dose inhaler is that they are very compact and portable. Treatment time is very short. There is no drug preparation required as in a nebulizer, and dose-to-dose reproducibility is you are getting the same sort of dose every time you use it, and the contamination of the contents is low. Of course, the major disadvantage of a metered dose inhaler is that if you are not using a spacer, you have to have very good coordination between your breathing and activation of the device. So therefore, I actually personally do not give a metered dose inhaler in most circumstances without a spacer, because actually the side effects are also higher and the effect is lower. It's very difficult to actually get good coordination between these two. High pharyngeal deposition can be there in a metered dose inhaler, and this cold freon effect is that when this propellant goes and hits the back of your pharynx, it produces a cold effect, and some people get coughing and difficulty in breathing, and so they can't take in a deep breath because of the cold freon effect. In our usual metered dose inhalers, we don't know how much dose is there, and so therefore people tend to run out without knowing they are running out. Of course, there are some of the metered dose inhalers now having a dose counter. Of course, because of this inhalation, you can spray it along. The children go and spray it to various people, trees, dogs, various people. So you're losing the very expensive drug. And of course, now this last line is not applicable now, because our inhalers are all HFC, which are not having any CFC. CFC, as you know, is air pollutant now, is considered air pollutant. So giving an inhaler is very important to know the technique. So let's see whether we can play this.
Hello, I'm Omar Osmani. I'm a consultant respiratory physician. I'm going to show you how to use what's called a pressurized metered-dose inhaler, or PMDI. It is also sometimes known as a puffer. Getting your inhaler technique right is very important because it helps you manage symptoms better. It may take a few tries to feel comfortable using your inhaler, but it does get easier with practice. If your doctor or nurse has advised you or your child to use a spacer with your inhaler, watch our other videos on using a spacer. When you first get your inhaler, or if you haven't used it for 5 days or more, you will need to test it. To do this, take the cap off, shake the inhaler well, pointing the mouthpiece away from you, press the canister to release a puff into the air. How many test sprays you need to do will depend upon your inhaler, so do check the instructions. This means it is now ready for use. Some PMDI inhalers have a dose counter. If yours has one, check it is not empty. Now, hold your inhaler upright and take the cap off. Check that there's nothing inside the inhaler mouthpiece. Shake the inhaler well. Sit or stand up straight and slightly tilt your chin up as it helps the medicine reach your lungs. The next steps all happen smoothly in one action. Breathe out gently and slowly away from the inhaler until your lungs feel empty and you feel ready to breathe in. Put your lips around the mouthpiece of the inhaler to make a tight seal. Start to breathe in slowly and steadily, and at the same time press the canister on the inhaler once. Continue to breathe in slowly until your lungs feel full. Take the inhaler out of your mouth and with your lips closed, hold your breath for up to 10 seconds or for as long as you comfortably can. Then breathe out gently away from your inhaler. If you've been prescribed a second puff, wait 30 seconds to a minute and shake the inhaler again. Then repeat the steps. When you have finished, replace the cap on the inhaler. If you've used an inhaler that contains steroids, rinse your mouth with water and spit it out to reduce the chance of side effects. For more tips on using your inhaler,
So that's how you use without a spacer. Main thing is you're tilting your head up because you open up the airway straight away rather than the inhaler going and hitting the back of your pharynx and therefore more deposition in the upper airway. So and then of course rinse out your mouth at the end. Of course this combination has been now, there are inhalers, we don't have it in Sri Lanka. We have the autohalers where there is, you don't need coordination. You prime the inhaler by putting this switch on top, you put it up and then the inhaler is primed, and as soon as you put it in your mouth and inhale, with the inhalation the drug is delivered. So therefore the coordination of pressing the inhaler is taken out of the process, so it has a better coordination, so you don't need a spacer for this device. So that's with regard to using a spacer without a spacer. If I would actually rather prefer giving a spacer when I'm giving